Thank you for joining us. My name is Jenny Pagel-Guile, and I am the Executive Director of the National Pancreas Foundation. Our mission is to provide hope for all of those suffering from pancreas disease through funding cutting-edge research, providing support and education, and advocating for better services and access to care. Some of the impact of the National Pancreas Foundation is awarding over 5 million grants to up-and-coming researchers to keep them in the pancreas field and moving care and treatment forward. We've endorsed over 180 centers of excellence across the country, from cancer, pancreatitis, and pediatric, recognizing that there are needs for all of our patients and, again, elevating the highest level of care. We also provide a variety of programs to volunteers, care providers, and medical professionals as well. There are many ways that you can be involved in the Pancreas Foundation, as well as several resources available online and on demand. We have the animated patient that provides detailed information about the diagnosis as well as the pancreas itself. We co-sponsor Camp Hope with Rebecca's Wish, our first pediatric pancreatitis camp in the country, and we provide nutrition support through our cookbook services and online webinars. All of this information can be found on our website, as well as a listing of all of our active centers of excellence. Across the country, we have over 30 chapters. These are volunteers and individuals who provide support to each other. They also provide grassroots efforts at tabling at local health fairs, providing fundraising support and education. They also sit in on advocacy calls at the local and national level. We would love to have you join us if you are able, or you can start a chapter in your community. Reach out to our staff if you would like to receive more information. Again, we have a full calendar of events, virtual and in person, on our website. We have an assortment of galas across the country. We have patient education events coming up in person, as well as medical professional events. And again, all of our webinars are available on demand online. The best way to stay up to date is to subscribe to our monthly newsletter. We also are on a variety of social media, so make sure that you follow us and share with your community and peers. We would love to have you join us. Now I would like to introduce our next speaker. Dr. Melina Bellin is a physician scientist and tenured professor in the Department of Pediatrics, Division of Endocrinology, and the Department of Surgery at the University of Minnesota. Her research focuses on pancreatitis, pancreatogenic diabetes, and on cell therapy for patients with type 1 diabetes and surgical diabetes. Dr. Bellin also serves on the National Pancreas Foundation Board of Directors.
Hi, thank you for having me. Thank you to the National Pancreas Foundation. I'm Melina Bellin. I'm at the University of Minnesota, and I am speaking today on pancreatogenic diabetes. I have some industry disclosures that aren't relevant to today's talk. So when you see patients in clinic who have pancreatitis and develop diabetes, you may see a lot of different terminology associated with this. And I just like to start off by introducing this so that people are familiar that unlike type 1 and type 2 diabetes that kind of go by a single name, this particular form of diabetes lacks a little consistency in the terminology. So you may oftentimes see this as pancreatogenic diabetes or type 3C diabetes. The American Diabetes Association has also used the term pancreatic diabetes, and some groups have used the term post-pancreatitis diabetes to really specifically refer to diabetes in the pancreatitis setting. But generally speaking, all of these forms of diabetes, or all of these terms, are used generally speaking to refer to a form of diabetes that's caused by exocrine pancreas disease. And for the purpose of today's talk, I'm going to speak most specifically to the form of pancreatogenic diabetes that occurs in people who have chronic or acute pancreatitis. I do want to emphasize, though, to start off here that compared to what we know about type 1 and type 2 diabetes, the data we have for this form of diabetes are really still, I would say, in its infancy. This is still very much an evolving field. We're still learning a lot about pathophysiology. And to be honest, we really have very little data at all when it comes to treatment. And so there's a number of studies going on within the US and around the world that will hopefully help us to address this. Within the US, there's a couple of consortiums that have been sponsored by the National Institute of Health. and specifically the NIDDK, excuse me, that help us learn about the pathophysiology in both and also the natural history of diabetes and acute and chronic pancreatitis. So what we do know is that diabetes is a very important and common metabolic sequelae of both chronic and acute pancreatitis. And so if you take a patient who has chronic pancreatitis, the initial manifestations of chronic pancreatitis may be pain, but as that disease progresses, the risk of diabetes goes up. And if you look cross-sectionally at children with chronic pancreatitis, about 8% or possibly more will have diabetes. And if you look at adults with chronic pancreatitis, about 35 to 40% of adults have diabetes. But what we have recognized over the past 10 to 15 years is that even in simple, uncomplicated, non-necrotizing acute pancreatitis, there is a risk for diabetes. That risk for diabetes very likely goes up with more severe disease and pancreatic necrosis, but it is not zero for people who have mild acute pancreatitis. And overall, that risk is still, we're still learning more about that risk, but it's probably somewhere around 15%, somewhere between about 12 to 20% at 2 to 3 years after an episode of acute pancreatitis. And it is higher than you would expect for just someone in the general population that you are following. So these are really important complications of chronic acute pancreatitis that you need to be aware of if you're following these patients or even just seeing diabetes patients in clinic. How common, so that's how common it is in people who actually already have pancreatitis, but how common is this form of diabetes overall if you look at the general population? I will say it probably depends on the specifics of the population you're looking at. There was a study that came out a little over 10 years ago from a German population, a tertiary care setting, a specialized hospital, where they reclassified all of their patients with diabetes, and that's the figure up in the right-hand corner. And about 9% of that diabetes was attributed to pancreatitis or to type 3C diabetes, to exocrine disease, mostly to pancreatitis after reclassification. But that might be a biased cohort because those are patients who are coming into a specialty institution for care. If you look at more of the general population, however, and you look specifically at adults, there are large population databases out of England and New Zealand that suggest that this form of diabetes, pancreatitis-related diabetes in adults, is just as common as new onset type 1 diabetes. So it's not as common as type 2, but it is not rare either. And so we need to keep that in mind when you're seeing patients with diabetes in your clinic or patients with pancreatitis. There are some real challenges here. If you have a patient with type 1 or type 2, you can go in and you put an ICD-10 code in and you can accurately classify them as type 1 or type 2 diabetes. We don't have that luxury with type 3C diabetes or pancreatogenic diabetes. There's sort of a secondary diabetes code, but it's not specific to pancreatitis. So there's a lot of miscoding, and also for insurance reasons, there's some miscoding to get access to supplies, CGM, someone might need to be coded as type 1 or type 2. We also have challenges with chronic pancreatitis that goes either undiagnosed or just sort of under-recognized as a cause of pancreatitis, particularly if someone's not in the GI clinic. And to be honest, there's some overlap in these conditions, and I'll tell you a little bit about that as we go through the pathophysiology sections, but it's not always as simple as this is type 1 or type 2 or type 3C diabetes, so that does create some confusion. So if you have a patient who has chronic pancreatitis, or for that matter, acute pancreatitis, how often do those patients need to be screened? And for the very first time, the American Diabetes Association in the last couple of years has included that in their standards of care guidelines. So the ADA has the standard of care guidelines that has largely focused on type 1, type 2, to some extent cystic fibrosis, gestational diabetes. And in the most recent iteration, they included pancreatic diabetes, pancreatogenic diabetes, and recommended that for patients who have acute or chronic pancreatitis, that they are all screened for diabetes. And the recommendation is that for patients with known chronic pancreatitis or recurrent acute pancreatitis, that's yearly screening. And for patients who have a new episode of acute pancreatitis, never previously affected, to have screening 3 to 6 months after that episode occurs, and then annually. And this can be very simple. A hemoglobin A1C level and a fasting glucose are oftentimes probably adequate screening for this. If you had concerns, if someone seemed like maybe they had diabetes, but you're not quite picking it up on the A1C, or they have a condition that makes the A1C inadequate for diagnosis, you could certainly consider doing an oral glucose tolerance test for increased sensitivity. So I want to spend a lot of this talk just talking about why this form of diabetes occurs, and summarize kind of the overall perspective here in this slide, but we'll go into a little bit more of the nuanced details in subsequent slides. But largely, for a big component of this is patients who have pancreatitis have a defect in insulin secretion. So they have an insulin deficiency or insulin insufficiency, depending on how you want to term that, compared to people who don't have acute or chronic pancreatitis. And this can result certainly from direct loss of islets. So patients who have chronic pancreatitis, they get fibrosis of their exocrine pancreas. As a bystander kind of consequence of this scarring, their islet tissue is also destroyed and you have islet loss. Or in acute pancreatitis, if you in particular have someone with necrotizing acute pancreatitis, they've destroyed part of their pancreas and have islet loss. It's probably not just islet loss. There's certainly evidence that there can be inflammatory related beta cell dysfunction, and patients who have acute and chronic pancreatitis have a lot of intrapancreatic inflammation and high cytokines within the pancreas. And we see that there's some of this defect in insulin secretion even before diabetes onset. So it's not that you go from not having diabetes to boom, you have diabetes. There is a progression in reduced insulin secretion that occurs before diabetes onset. But where it gets more interesting, or also as interesting, is that this is probably not just a defect of insulin secretion. So there are certainly patients, it may not be all, but certainly at least a subgroup of patients who have pancreatitis and diabetes who have insulin resistance. And most particularly, this has been demonstrated to be hepatic insulin resistance, with sort of mixed data on whether or not patients have peripheral insulin resistance, meaning insulin resistance at the level of the skeletal muscle. But there's certainly good evidence that at least some of these patients with acute and chronic pancreatitis have insulin resistance that's further contributing to this picture in the context of also having insulin deficiency. And then there's other hormones that are abnormal, have been demonstrated to be abnormal in chronic pancreatitis at least, but are perhaps less clear in how they might affect pathogenesis and development of pancreatitis. And so we do see that patients with chronic pancreatitis make less pancreatic polypeptide in response to a meal, at least in the adult population. We haven't replicated that yet in pediatrics, but at least in adults. And then some studies certainly demonstrate that there is a deficit in GLP-1 and or GIP, perhaps related to malabsorption, that may be correctable by administering pancreatic enzyme therapy, but it's not clear. It's less clear how that affects diabetes development directly. So those are areas needing a little bit further study. So how do we know that there's this insulin secretory defect and beta cell injury and loss in chronic pancreatitis? Well, we know that from both looking directly at the pancreas and looking at population-based studies. So on the left-hand side is a published study from about 15 years ago, looking at autopsy and surgical specimens from patients who had chronic pancreatitis with or without diabetes, and looking at beta cell area, so the cells that are producing insulin, and showing that those patients who have diabetes with chronic pancreatitis had a reduced beta cell area. So they had evidence of more actual direct beta cell or islet loss. On a population-based level on the right, we also see this reflected in the fact that, and this is a particular study that came out of the United Kingdom, that when patients are newly diagnosed with diabetes following acute or chronic pancreatitis, which are the pink or green lines respectively here, compared to type 2 diabetes, they have a much more frequent and quicker progression to needing insulin therapy. So their diabetes is not oftentimes not well treated by using non-insulin therapies, and they require insulin to maintain glycemic control more so than people with type 2 diabetes do. So just highlighting that this patient population has a bigger insulin deficit clinically as well. There are also studies of using oral glucose or mixed meals or IV stimulus to look at insulin C-peptide response in people who have chronic pancreatitis and don't, that demonstrate these same types of deficiencies in insulin secretion clinically. So we also have a group that is out of India who looked directly at intrapancreatic inflammation in patients with chronic pancreatitis with or without diabetes who were having surgery, pancreas resections, compared to control subjects who had pancreas disease but not pancreatitis leading to pancreas resections, and demonstrated that within the patients who have chronic pancreatitis, the inflammatory cytokines are significantly elevated, but even more so if you look directly at patients who have diabetes and chronic pancreatitis. And in particular, one of the inflammatory cytokines that has been highly cited here is interferon gamma as being significantly increased in diabetes and chronic pancreatitis. And there is evidence that increased expression of interferon gamma can reduce glucose-stimulated insulin secretion in vitro. And so the importance, I think, of understanding this inflammatory component is that unlike islet loss, this is a component that might actually be reversible or treatable. So I think it's important to understand the relative contribution here. So something that I bring up in the clinical setting more for awareness. I think this is something that would affect a small set or a small subset of these patients who have pancreatitis and diabetes, but we do have some data that suggests that in some of these patients, particularly with more significant disease, recurrent acute or chronic pancreatitis or hereditary pancreatitis, that some of these patients might actually develop autoimmunity. Characteristic of type 1 diabetes. So, and I bring this up, this is the data here is a case series that we had seen at the University of Minnesota a number of years ago and subsequently published with patients presenting with positive autoantibodies, typical of type 1 diabetes, negative C-peptide, and some of them were having surgery where we even were able to demonstrate on histopathology classic islet inflammation that is typical for type 1 diabetes. So it seemed like a real, truly type 1 diabetes immune process. And then there's our other larger cohort studies that we've collaborated on, other investigators have published on in both adult and pediatric chronic and acute pancreatitis, showing some signs of islet autoantibodies classic for type 1 diabetes at a population level in these patients and connected to an increased risk of diabetes as well. So I bring that up to a clinical audience, mainly to highlight that if you're seeing a patient in front of you who has pancreatitis and diabetes, and particularly if they present with severe hyperglycemia, ketosis, and don't take type 1 diabetes off your list just because they have pancreatitis. Do think in some of these more rapid progression, rapid presentation, severe hypoglycemia, ketones. I think you need to be also thinking about type 1 diabetes and testing for autoantibodies if you see that pattern occur, because there are some different risks for type 1 diabetes in terms of other autoimmune comorbidities, risk of DKA. And so it's important, I think, to be aware if that's present. It is more, as I said, more than just insulin secretion defects. There's good evidence for insulin resistance, again, at least in a subcohort. I'm not sure if this applies to the whole population. It might apply to a big subpopulation. We see that from several pieces of evidence. So there are very specialized studies you can do that are very expensive and very involved called euglycemic clamps, where you actually keep a high rate of insulin infusion and look at how much dextrose is required to maintain euglycemia. And you can calculate from that a marker of insulin resistance, and you can look specifically by using tracers at how much of that is hepatic insulin resistance. So that gold standard level evidence does demonstrate hepatic insulin resistance. These studies largely done in men with alcoholic pancreatitis, so I'll give that caveat, but kind of bigger population evidence. We see in patients who have acute pancreatitis and then develop diabetes that they have more visceral adiposity. So sort of think classic metabolic syndrome, fat in your liver, central adiposity in those who develop diabetes. And then we also see genetic similarity markers between type 2 diabetes, which we classically think of as an insulin resistance problem, and diabetes and pancreatitis. I also just want to highlight that these changes are in insulin sensitivity and disposition index are, again, present before someone actually develops diabetes. And because we have a number of patients at our center who are in studies for their total pancreatectomy islet auto transplant, where we do specialized metabolic tests before they have surgery, we were able to use some of that testing to compare to perfectly matched healthy controls, same age, same BMI, same sex, and could demonstrate using sort of more sophisticated testing that's done in the clinic, that even though these patients that we were assessing for surgery didn't yet have diabetes, they were non-diabetic, they did have more insulin resistance and reduced insulin secretion, particularly early insulin secretion compared to healthy controls. And those deficits were much more pronounced if you had calcific chronic pancreatitis. So you can think of calcifications on imaging as sort of implying more severe fibrosis, more severe scarring, and that is associated with reduced C-peptide as a marker of insulin and reduced glucagon secretion. So the other hormone that is being studied in this patient population, you don't hear a lot about it in the other forms of diabetes, is pancreatic polypeptide. Pancreatic polypeptide is a meal-stimulated hormone that also comes from the islets. It comes from the PP cells of the islets, not the beta cells. And if you look at pancreatic polypeptide in patients who have type 2 diabetes, which is the top black line in this figure, and then this particular study also had pancreatic cancer. So that's the middle line is pancreatic cancer. And then compared specifically to patients who have chronic pancreatitis and diabetes, which is the gray line that's at the very dashed line at this very bottom here. You see that there's a really significant deficit in adults with chronic pancreatitis in their meal-stimulated pancreatic polypeptide as opposed to type 2 diabetes. And so one way that this might be useful in the future, and it isn't a tool to use in the clinic right now, is there's some question as to whether this could help us distinguish patients whose diabetes is primarily driven by chronic pancreatitis versus more classic sort of type 2. The reason I say you can't be used in the clinic right now is the assays aren't standardized and there's no actual cutoff value for diagnosis, so it isn't quite helpful yet. The other question I think that's interesting here is, and is much less explored actually, is whether PP might contribute to the pathogenesis. So when the researchers, this is Dr. Dana Anderson and colleagues, had done these euglycemic clamp studies where they looked at hepatic insulin resistance, if they actually administered IV infusions of pancreatic polypeptide, they were able to reverse that hepatic insulin resistance. So there is some question as to whether this might actually be important in informing future treatment modalities, but those treatments don't exist currently. So what are the treatments that we have currently for this form of diabetes? So I'm going to say this with the caveat is there are no results from clinical trials, none. There's no results from clinical trials. There is an ongoing clinical trial that I'll reference in a few slides, but this is really just informed by understanding of pathophysiology, evidence from type 1 and type 2 diabetes, and expert opinion. And so since most patients have insulin deficiency or insulin insufficiency, insulin is oftentimes, frankly, it's required in many cases for adequate glycemic control. It's most directly addressing the physiologic defect for many of these patients, but it does have a disadvantage of hypoglycemia risk. That's obviously our risk with insulin therapy is for hypoglycemia and more glycemic lability. I want to bring up here that these patients have malabsorption, and so a lot of times this lability or hypoglycemia is thought of as a glucagon deficiency problem, and that may be part of the picture. We need more data, but I think it's also a malabsorption problem. And so one important unique aspect to treating diabetes in this patient population is also making sure they're getting good GI care, getting adequate doses of pancreatic enzymes, and not having malabsorption so that you don't have this variability in what they're absorbing with their meals because your insulin is matched to that. I also think there's probably, although we don't have a lot of data on how often these are used, but my anecdotal perception is probably underuse of diabetes technologies in this patient population. These are probably patients who really benefit from being on continuous glucose monitors if they're on insulin, particularly to detect hypoglycemia. And I think those are being used more and more frequently. But insulin pumps, I think, are also incredibly useful in this population. Insulin pumps are technically actually technically approved for type 1 diabetes and 1 or 2 cases for type 2 diabetes, but they're not specifically labeled for this form of diabetes. And I think that does, to some extent, lead to their underutilization. But for someone who has glycemic lability, these are great systems to automate insulin delivery from the sensor input. So what are the other treatments that are used? So other than insulin, the main treatment that's been used clinically is metformin. It has some appeal. It's cheap, it's easy to get, it's pretty well tolerated, it's pretty safe. I guess with the exception of holding it if someone's dehydrated or sick because of lactic acidosis risk. And it may actually be appropriate for some of these patients. If you have someone who looks more like type 2 diabetes, they're obese, they have a high C-peptide or high insulin level, their hyperglycemia is relatively mild, this might be okay as a starting point. My caution about metformin is the way it works is decreasing insulin resistance. So if you have a thin, insulin sensitive, low C-peptide, significant hyperglycemia patient in front of you, I don't think this is going to do much for your treatment. You could combine it with insulin, but it's probably not going to do anything alone. There is this maybe theoretic benefit that I think is not well established, but there were some sort of case control and epidemiologic studies in type 2 diabetes, which is different, obviously, than pancreatitis-related diabetes, that using metformin might reduce the risk of pancreatic ductal adenocarcinoma, so that it might have some protective effect against cancer, which these patients are definitely at increased risk for pancreatic cancer. So there's a whole slew of new treatments for type 2 diabetes, or newer treatments for diabetes. And probably the biggest ones that have gotten a lot of use, in part because of weight loss, in part because of kidney and cardiovascular protective effects, are the group that are SGLT2 inhibitors and the group that are GLP-1 receptor agonist therapy. There's also some older drugs like pioglitazone, the TZDs are the category there that might have some appeal. And so there is actually a study of the TZDs and the SGLT2 inhibitors, a pilot study that's currently recruiting. So hopefully we'll actually have some data on some of these other therapies, but we don't have that data yet. The SGLT2 inhibitors are probably okay. I think the thing to be aware of there is that in type 1 diabetes, where people are completely insulin deficient, there's a risk of DKA on SGLT2 inhibitors. So just be aware of, and it has been reported in pancreatitis and pancreatectomy as well. So just be really aware of that risk and need to watch for ketosis. The GLP-1 receptor agonists have been pretty controversial because they were associated initially with pancreatitis, and there was an FDA kind of black box warning about pancreatitis. If you take general population type 2, the evidence is favoring that general population. It doesn't really have an increased risk of pancreatitis. Maybe the DPP-4 inhibitors, the pill kind of versions of the GLP-1 based therapies might have a small increased risk. But I want to say I don't personally use these in someone who has significant pancreatitis history, because they haven't really been studied in this group, in the group of patients who has chronic pancreatitis, who has hereditary pancreatitis, who may be at high risk. And I do think there's, there should be a bit of caution just in considering these type of therapies. So very last, just a couple slides to end out on thinking about long-term consequences of this form of diabetes and monitoring. There's not actually a lot of data here that comes from the US, so I'm going to show you a couple international studies. And so there's a study out of Taiwan that looked at the nationwide data on diabetes in patients who had chronic pancreatitis and those who didn't. And I'm sure, depending on the size of your screen, these figures might show up a little bit small here. But the take-home point of this study from Taiwan is the data that they had in their nationwide database suggested that patients with chronic pancreatitis who have diabetes were at increased risk for hypoglycemia, increased risk for DKA, and increased risk for mortality. So be aware of those potentially elevated risks in this patient population compared to what was probably mostly type 2 diabetes, because most diabetes without chronic pancreatitis statistically would be type 2. There's also data coming out of a European population looking at hazard ratios or odds ratios for developing various complications in the setting of diabetes, and the ones that were most increased in risk in pancreatitis diabetes compared to type 2 diabetes were a fourfold increased risk of developing infections, but also an increased risk of hypoglycemia in that population as well as a composite measure of microangiopathy, so a composite measure of developing diabetes, kidney, eye disease, or nerve disease. And so these patients should be screened for diabetes complications annually, like you would with someone with type 2 diabetes. So eye exam, urine microalbumin, foot exam, all of these things assessing for neuropathy. So in summary, patients with acute pancreatitis, recurrent acute or chronic pancreatitis should be screened yearly for diabetes. You can do that with a hemoglobin A1C and fasting glucose, or frankly, if they're in your clinic in the middle of the afternoon and all you can get at that point in time is a hemoglobin A1C, get some screening on these patients. The diabetes and chronic pancreatitis, it's primarily driven by an insulin insufficiency, but also probably complicated by insulin resistance in a number of patients. And there's a whole lot of work still going on in understanding physiology, and understanding the pathophysiology is actually really important in deciding what's appropriate for treatment. The pancreatic polypeptide might be a future biomarker to distinguish this form of diabetes, and do kind of keep on your radar also monitoring or testing for type 1 diabetes if you have a particularly acute presentation. In terms of treatment, insulin is oftentimes required. In some cases, you might be able to start with metformin, or rarely consider another type 2 diabetes medication, depending on the specific clinical circumstances. But just realize that in 50% of the chronic pancreatitis cases, you're going to end up needing insulin. So be watchful for that. For glycemic control, I do recommend continuous glucose monitors for the insulin users, and please do make sure these patients are getting monitored for acute and chronic complications of diabetes, and that doesn't get lost in the shuffle of their pancreatitis care, which on its own can be so complex. So with that, I will wrap up. I'll just acknowledge a really wonderful team that I work with at the University of Minnesota for care of patients with chronic pancreatitis through medical, endoscopic, and surgical therapies. And I have a very robust clinical research team. We're always trying to learn how we can treat patients with pancreatitis better and offer more than what we have in the clinical realm right now. And so with that, I will end. And thank you for your attention.